People are still coming and joining, but we'll go ahead and get started, being mindful of everyone's time. So good evening and welcome to the second of our 3 webinars in our Breath of Fresh Air updates for asthma and COPD in primary care webinar series hosted by the Physician Learning Program and Office of Lifelong Learning. Today's session is targeted screening and management of COPD in primary care. My name is Denise Campbell-Sher. I'm the Associate Dean of the Office of Lifelong Learning Physician Learning Program and a family physician in the Edmonton Southside Primary Care Network. The Physician Learning Program creates actionable clinical information by engaging with physicians, teams, partners, and patients to co-create sustainable solutions to advance practice. The PLP is dedicated towards moving evidence into practice and fostering a culture and environment where everybody works together to tackle our most pressing problems, advance patient care, and create a world-class sustainable healthcare system, which improves important topics like COPD. Next slide, please. So we acknowledge that we are gathered here today on the traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. So in terms of logistics, if you have a question for Dr. Bhutani, please use the Q&A feature on the bottom of your Zoom screen. If you have a technical question, please use the chat feature. Please have a look at what questions have been asked and upvote those questions that you'd really like to have answered. We know from the pre-engagement that there's tons of questions, probably more than we can get to today, but we're already thinking and planning about additional opportunities and webinars to address those. Just in terms of logistics, everyone who registered for today will receive a recording of the webinar and a PEARLS document with resources. If people are MainPro Plus participants, you can earn certified credits by completing the Linking Learning to Practice exercise in MainPro Plus. And MOC and MainPro Plus credits can be learned by completing a personal development activity using the My L3 Plan tool. We'll talk a little bit more about that at the end of the session. This activity has not been formally reviewed by the CFPC or Royal College, but it is also eligible for non-certified credits. Stop sharing, Mohit share screen. Thanks so much. Now I'm going to do some intros for Mohit. So we're really pleased today to welcome Dr. Mohit Bhutani, who's going to be presenting to us. And we want to extend a special thank you as well to Dr. Kasia Malchuk, who's a family doctor from the Willow Family Medical Clinic, for her contributions in shaping this webinar. So Mohit is a professor of medicine at U of A, and his main interests are in the fields of asthma and COPD. And he's been involved at every level in works of this in this sphere. He is the clinical director of the asthma and COPD clinics at the U of A, and provincially he's the co-chair of the Alberta Health Services COPD Connect Care Pathway Development Program. From 2014 to 2020, he was co-chair of the Airways Working Group and the AHS Respiratory Health Strategic Clinical Network. And nationally, he's the past co-chair of the Canadian Thoracic Society Clinical Assembly. He's one of the lead author on the CTS COPD pharmacotherapy guidelines. The most recent iteration was 2023, and we're going to hear about those today. And he was elected to the CTS executive in 2020 and is the current president of the CTS. He was co-chair of the Royal College of Physicians and Surgeons Adult Respiratory Examination from 2017 to 2023, and has oodles of research interests in this area with lots of funding from lots of agencies, including CHR and Alberta Innovates. So very much thanks to everyone who's come. And I know, being the timing at the end of clinic, I know I would be hard pressed to wind up. So I suspect people will be popping in, Mohit, as you get going. But thanks so much for being here today.
Great. Thank you, Denise, for that kind introduction. Good evening, everybody. Can't physically see you, but this is it's good to have you all back. And this is the second session that we're doing today. The first one was on asthma, and now we're talking about COPD and targeted screening and management of COPD in primary care. I'm particularly very excited to talk about the 2023 guidelines. I am one of the lead authors of the guideline. It's a very proactive pharmacotherapy management for patients living with COPD. And we think it's the best guideline in the world to provide our patients with living with COPD with the best outcomes. And we'll get into that in a little bit. So these are my disclosures. I have three learning objectives for you. First of all, is to think COPD, review, and what we're going to do is review the diagnostic and risk assessments for COPD to help you along the way when you are thinking about COPD. I'm going to summarize the new recommendations from 2023. We published them in mid-September of 2023. They've garnered a lot of attention provincially, nationally, and around the world. And I'll update you on some exciting developments from that. And then we'll select a bit of a comprehensive approach to COPD management as well. What else beyond pharmacotherapy should we be thinking about and doing for our patients with COPD? There was a needs survey done before. I've been allotted 30 to 35 minutes today to talk about COPD management. I probably won't address all the questions or in that time frame of what was asked, but perhaps in the Q&A, and as Denise alluded to, perhaps maybe a third session may be needed, but we can cross that bridge when it comes. So walking away from this talk, one of the things I would really ask for you to do is to think COPD. It is the third leading cause of death worldwide. It is often and is still the number one cause for hospitalizations in this country. And the reality of it is that there's a lot of work that can be done in the outpatient world to prevent some of the acute care burden and improving patients' lives who are living with COPD, and particularly those ones who are undiagnosed, maybe in the early stages of the disease. And I'll show you some data to suggest why that's important. So who should we think about COPD in? Despite the prevalence of smoking, tobacco consumption going down across the country, tobacco exposure still remains the number one cause for the development of COPD. It is still the thing that we need to think about as the most significant risk factor. But there are a number of different exposures that can lead to the development of COPD. One of the things we ask you to maybe reflect upon in asking your patients is about their occupational history. We know farmers, welders, folks that may work in the oil and gas industry all have an increased prevalence of COPD. We talk about pollution, indoor and outdoor pollution, and the disease in the face of COPD is changing because of this, because we have a lot of immigrant population coming into the country, and a lot of those patients come from areas of the world where the pollution is quite profound, both indoor and outdoor pollution. And at the end of the day, we need to think about things and exposures other than tobacco that may lead to the development of COPD. So occupational exposure, indoor pollution, outdoor pollution, and then immigrants that may come from parts of the world where tobacco legislation may not be as robust. One particular group to think about is, if you've heard me speak before, there's a lot of literature developing in South Asian women who have never smoked a day in their life, but because they've lived at home, they've been housewives, and at the end of the day, they've cooked in an environment with biofuels, with poor ventilation, and they develop COPD, unfortunately. And so just kind of thinking about not just the typical older Caucasian male smoker, it's thinking about different faces that may reflect the population that may be at risk for the development of this disease. And then, of course, there's also the family history of COPD. There is a rare condition called alpha-1 antitrypsin deficiency. It is when you're deficient in that enzyme, and you can develop COPD whether you smoked or not. If you smoke, it's almost a sure thing you will. If you've never smoked, there's still a possibility for developing that disease. And so I want to highlight that because there's been some changes in the funding model across the country. Alpha-1 antitrypsin replacement has traditionally been hard to get. In this province, there's the STED program has had the support for alpha-1 antitrypsin replacement on pause since 2019. Late in 2023, in November, Canadian Blood Services has taken over the contract, and now alpha-1 antitrypsin replacement is available ubiquitously across the country. A little bit different in Quebec versus the rest of the country, but the rest of the country is on sort of the same program. And if you are deficient in alpha-1 antitrypsin, you meet the requirements for treatment, patients will now have access for this. So thinking about family history is important. I was asked to present a few slides on the CPSN, the Canadian Primary Care Sentinel Surveillance Network. So this is a pan-Canadian group of networks of primary care physicians whose EMR feeds essentially into a central EMR where we can get really important ground level data on patient care and management within the primary care world. There is a program called NAPGRN, which is the Northern Alberta Primary Care Research Network. It is essentially the Alberta, Northern Alberta subsidiary of CIPSIN. And as you can see here from this slide, there's about 90 participating family physicians and nurse practitioners in 16 practices that extract data from structured EMR of 107,000 patients. So really, really robust data that comes from both CIPSIN and from NAPGRN. And so we've got some very interesting data here to show you in regards to what's happening within this NAPGRN database as it relates to COPD and smoking. So from the NAPGRN database, you see that within this region of Alberta, the proportion of patients with a diagnosis of COPD in these EMRs is around 10%. And that's a little bit lower than what I would have expected, given the fact that the smoking prevalence in Northern Alberta is higher than it is in Southern Alberta. The national average sits around 10 to 12%, depending on kind of where you look. So I'd expect that this would be maybe a little bit higher than what we're seeing right now within the NAPGRN database. And so coming back to that concept of thinking about COPD and that patient at risk. Of the patients who have documented COPD in regards to what type of smoking history they've had, if there's any documentation of smoking in the COPD population is around 80%. So there's a bit of room to improve in terms of making sure that you know what your patients with COPD, whether they're active smokers, not active smokers, what's their smoking history, what's their current pack smoking history, in order to provide them with the right therapies such as smoking cessation counseling. Lastly, about a third of patients with COPD right here are current smokers. So there is this group of patients where smoking cessation strategies should be discussed and should be engaged with the patient, as we do have resources in this province such as Alberta Quits that could help you along that journey. So this is just a little bit of a snapshot of the type of work that can be done from participating in programs like NAPGRN. We can get a sense at a population level what's happening with our patients and when it comes back down to what you're doing in your own practices for COPD management. One of my biases for COPD is that we often diagnose the disease late. It's often the disease is often diagnosed in the moderate to moderately severe disease state when the lung function testing is done. And I think there's this window of opportunity to intervene if COPD is thought of earlier. And this slide by Sutherland, if you've ever seen me speak, I've been showing this slide for 15 years now. It shows that there's this, on this y-axis, the red y-axis, a slow decline in lung function. And on the blue y-axis, you see a slow increase in symptoms. And so while the lung function is slowly going away, Sutherland in this article calls it this asymptomatic phase. And I disagree with the fact that it's asymptomatic, because I think what ends up happening here is that patients who smoke have an expectation of symptoms such as cough, sputum production, recurrent bronchitis, activity limitation due to breathlessness. And so, all smokers, I think, expect this. And all the while, 1 in 5 of them have a slow loss of their lung function. And it's not until the symptoms become very progressive, the third or fourth bronchitis or the cough that doesn't go away after a viral infection, or they start coughing on more and more mucus, or there's some sort of lifestyle limitation as a result of the breathlessness that they complain to you, and that's when COPD gets diagnosed. And so oftentimes, this happens in the moderate to severe range of COPD. So I think there's this window of opportunity for us to intervene earlier where they've not lost their lung function as significantly, and where some of the interventions that we have can actually change the natural trajectory of the disease. So what ends up happening with these patients who are continuing to smoke and have these symptoms? Well, they become dyspneic with activities, and what do? They don't necessarily stop smoking or change their work or those sorts of things. They become more sedentary. So they start taking the elevator, start taking the stairs, they start taking the elevator, they maybe stop, not going for runs, they go for walks, that sort of thing. They become more sedentary, which is probably the worst thing that they can do, because that's when we see some of the secondary cardiovascular comorbidities that develop in this population. And on top of that, they become very deconditioned. And so those, 2-3 things come together and creates the perfect storm for a deterioration in their overall health. And so we want to prevent them from getting to this point where they stop doing their activities and not become deconditioned, because it does impact the type of survival and type of outcomes that they do actually have. This study from Marino shows that when you've got moderate disease, so FEV1s of 50% or higher, patients with COPD die more of cardiovascular disease than they do of respiratory disease. So in the mild to moderate population, we see that they die more of cardiovascular disease, and we think it's due to this downward spiral that they actually experience. When they develop more severe disease and more prone to exacerbations and flare-ups, then you see that respiratory disease, tends to be more problematic, or they die more of respiratory disease than cardiovascular disease. But as you can see across the continuum of the disease, cardiovascular disease and mortality associated with it are very significant. So it all comes back down to this sort of downward spiral, this deconditioning that they develop. The dyspnea is quite problematic for them, and it actually predisposes them to exacerbations. And so this cohort from a year, or this slide from a European cohort, looks at patients who have an MMRC of 2 or less, and we'll come back to the MMRC in a little bit, but these are patients who are less symptomatic from a breathlessness standpoint versus those who are more symptomatic, 2 or higher. As you can see, the more breathlessness you experience, the more likely you are to exacerbate both moderate outpatient and severe inpatient exacerbations. You're twice as likely, if you're 2 or higher, to have a moderate to severe exacerbation on the dyspnea scale. Going to the hospital, you're 4.5 times more likely and 4 times more likely to be hospitalized if you have more dyspnea. So these are the things that happen. If we can prevent them from getting to these stages, we reduce their natural history of cardiovascular events as well as exacerbations. And these patients do present to primary care. And so this study from primary care in the UK shows that in the 5 years, and this is 40,000 patients, almost 40,000 patients, in the 5 years before they got diagnosed with COPD, 85% of them, there we go. 85% of them come for some sort of lower respiratory tract consultation. 68% of them get a prescription between steroids as well as antibiotics. They're coming, they're getting treated, but it's that next step of then sending them for spirometry to make the diagnosis. So if I can leave you with the thought, you want to think about COPD, okay? And take a look at the risk factors and take a look at their symptoms and see if they should go for screening spirometry. There is a tool called the Canadian Lung Health Test that can help you increase your pretest probability. So these can be uploaded into EMRs, they can be printed out, and patients can fill them out in the waiting room while they're waiting to see you. But essentially, it asks if patients are 40 years or older, who have ever smoked, and have a chronic respiratory symptom. If they say yes to any of it, they should be sent for screening spirometry, okay? And so it's a tool that's not perfect, but it's the only tool that we've got because it isolates it to 40 years or older and people who have smoked or used to smoke. So it doesn't incorporate all the other risk factors that we just spoke about, but it's something that we want to think about. The one thing I'll make sure that you do, like I reminded you with asthma, is that we want to send patients for spirometry. You do not need to send them for a full pulmonary function test. So spirometry, about a 15 to 20 minute test, costs about $85. Full PFT, about an hour, and costs around $250. So there's a cost savings and time savings for your patients if you send them for spirometry and not a full PFT. So just keep that in mind. We still use the GOLD classification on spirometry to define severity, okay? So the way we define severity is that you've got COPD, if you've got post bronchodilator FEV1 to FVC ratio of less than 0.7, and then the severity is based on the post bronchodilator FEV1. So you're mild if you're greater than 80%, moderate if you're between 50 and 80%, severe if you're between 30 and 50%, and very severe if you're less than 30%, okay? So we want at least one spirometry to confirm the diagnosis, and I'll get back to why I say just one is probably enough. When we approach the pharmacotherapy, now I've got a patient diagnosed with COPD, how do we assess them to make sure they get the appropriate therapies, whether it's pharmacological or non-pharmacological? And so there's 3 things that we ask our patients for you to do in order for you to get the right medication to the right patient at the right time. And the 3 parameters are, after the diagnosis is made with spirometry, is to use the MMRC score, You can use the CAT score, and you want to look at their future risk of exacerbations of COPD. That's it. Use one or the other or both if you're really keen. MMRC, CAT, one or both. And then you take a look at their risk of future exacerbations of COPD. You put that together, and that's your assessment, and then it provides you with guidance as to what patients should be on. What is the MMRC? That's a scale that goes from 0 to 4, and it goes from people who are diagnosed with COPD who are breathlessness with strenuous exercise to grade 4 who are having problems with activities of daily living. Grade 1 is basically going up a flight of stairs really quickly, making you short of breath. Grade 2 is walking on a flat level, making you short of breath. And grade 3, walking about a block before you become short of breath. So MMRC 0 to 4 is a tool you can use to assess their breathlessness. The other tool, the CAT score, the COPD assessment test, 8-question questionnaire on a Likert scale from 0 to 40. What we like about this score is that it measures other factors of COPD management beyond just the breathlessness. It talks about cough, phlegm production, chest tightness, confidence of leaving home, sleep. And what we know is that with a score of 10 or higher, it's an impaired quality of life. Why we sort of advocate for the score is that it's got a bit of a sliding scale on there, that if the score goes up, worse quality of life by at least 2, that's the minimally clinically important difference. That's a worsening quality of life. If it comes down by at least 2, that's an improvement in quality of life. So it provides you with a little bit of a scale to sort of say, well, what were they like, 3 months ago? Are they better? Are they worse? Are they the same? You've now got a scoring system with a minimally clinically important difference of 2 to tell you whether or not they're better, worse, same. So we think this is a valuable tool. Again, on EMRs, you could have this in your waiting room for patients to fill out and help you guide with your therapy. The third component is your future risk of exacerbations of COPD. Since 2019, we've had the same definition. We'd ask patients to be divided up into low risk of exacerbations and high risk. You're divided based on your exacerbation history. So in the previous 12 months, if you've had 1 or less outpatient treatment with an antibiotic and/or prednisone for your COPD, you are in the low risk of exacerbations. So this is outpatient treatment, and you did not go to the emergency department or the hospital. You have a high risk of exacerbations if you've had 2 or more of them in the outpatient treatments in the previous year, or 1 hospitalization or emergency department visit in the previous year. Okay. We went to these 2 definitions for future risk because that's how the randomized controlled trials that we used in our systematic review of the evidence has defined patients. So when they get entered into our RCT, they use these definitions for their inclusion and exclusion criteria. So we felt it was important to implement those into our guidelines, and this is the same as it's been since 2019. So how about the 2023 COPD pharmacotherapy guidelines? So this is our new algorithm for building blocks. Our goals of therapy are to alleviate dyspnea, improve health status, prevent exacerbations of COPD, and for the first time, we believe in an objective manner, we can reduce mortality, and we have the evidence to support this recommendation. When we were developing this tool, we recognized that there's a bit of a misinterpretation of this pyramid that we see here, and it's been that way for many, many years. When you look at this, and intuitively you would think it's a stepping stone approach to therapy. But in fact, it's never been that way. We've always wanted to have an assessment. Wherever you fit furthest to the right on this assessment on the base, you're supposed to draw a vertical line down, and all of those interventions that cross that vertical line are the interventions that you should think about for treatment for patients with COPD. So at the bottom, what are your assessment tools? What's the 3 things we just talked about? Your lung function impairment can still be included, so mild to very severe based on the GOLD classification. Your MMRC of 1 to 4, a CAT score of less than 10, remember 10 or higher is considered to be a poor quality of life, to 40, which is the maximum score you get on the CAT score, and then your exacerbation history, low risk and high risk based on what we just defined. Wherever you are furthest to the right of this, you draw a vertical line down, and that's what you should be using for treatment. At the very bottom, across the continuum of disease, you see the very big yellow block, which is all the things that we think are important for part of chronic disease management with COPD. And we'll get into that a little bit in a few slides. But self-management and education are important, smoking cessation if they're actively smoking, exercise, vaccinations, pneumonia, COVID, flu, and RSV if they are age appropriate for the RSV vaccine, and using short-acting bronchodilators across the continuum. New to 2023 is that anybody with a diagnosis of COPD should be on a long-acting maintenance bronchodilator. No more are we suggesting SABA first and then stepping up. We're saying that patients who are diagnosed with COPD should be at the minimum be on a long-acting muscarinic antagonist or a long-acting beta agonist. And I'll show you those slides in a couple of seconds. So maintenance therapy across the continuum of the disease. And then as the disease becomes more advanced, we think about adding pulmonary rehabilitation in, other pharmacotherapies, which are the oral agents, oxygen, and then surgical endoscopic. So assess them furthest to the right, draw a vertical line down, and those are the things that you should be thinking of. So here's the pharmacotherapy algorithm now. So based on CAT, MMRC, or lung function, mild disease is defined as a CAT score of less than 10, an MMRC of 1, or a post-bronchodilator FEV1 of greater than 80%. These patients have low symptom burden. They should still be, though, on a long-acting muscarinic antagonist or a long-acting beta agonist. The SABA has been dropped down to the bottom, so you're on a short-acting bronchodilator across the continuum of the disease. But if you've got COPD, even if you're mildly symptomatic, the evidence suggests you should be now on a maintenance therapy of some sort. You're moderate and severe if your CAT score is 10 or higher, your MMRC is 2 or higher, or your lung function is less than 80%. Then you divide it into the low risk, so 1 or less outpatient treatments of exacerbations of COPD, high risk, 2 or more outpatient treatments, or a hospitalization or emergency department. This is the group that has the highest risk of mortality as it relates to COPD. And this is the group we want to be most aggressive with. So going back to this low risk group, everyone here should be on a dual bronchodilator LAMA-LABA, so in a single inhaler. So using both bronchodilators as a first line therapy, and then stepping up to triple inhaled therapy in a single inhaler if they continue to be symptomatic of their disease, because you know the inhaled corticosteroid, when it added to this population, improves quality of life, it improves a bit of exercise endurance, and does reduce your risk of exacerbations. In this moderate to severe group at high risk of future exacerbations of COPD, we now recommend that everyone should be on single inhaler triple therapy, LAMA, LABA, ICS, in a single inhaler. That's with asterisks. And we put down the fact that this triple therapy in this high risk population reduces mortality, and that's what our evidence shows. If they continue to exacerbate despite being on triple therapy, that's when we think about oral therapies like your daily doses of azithromycin, your N-acetylcysteine, or if you've got chronic bronchitis, thinking of things like roflumilast. So this is our new algorithm. As I say, it's a very proactive algorithm. It's not waiting for our patients to fail and step up. We want them properly assessed and want them to be on maximal therapy to give them the best outcomes possible. We're trying to change the thinking because acute exacerbations of COPD have the same short-term with the 1 month and 1 year long-term outcomes as a heart attack. So if patients have heart attack, everything is done to prevent that next heart attack from happening. We're trying to bring that thinking into COPD, and it's not just us wanting this; it's the evidence that is guiding us to make these recommendations. So you've seen all of this is a map of the different inhalers that are available for COPD management. I would argue that for the vast majority of patients that you have in your clinical practice who are living with COPD or diagnosed with COPD, you're going to now reduce this large mess of inhalers down to 6 inhalers. You have your dual bronchodilators over here, so your LAMA-LABA dual bronchodilators. And then you've got 2 single inhaler triple therapies. You've got Trelegy and you've got Breztri, the 2 single inhaler triple therapies. So we often get the comment that this is just an overwhelming picture to look at. I think what we've done quite nicely with the guidelines, and again, the evidence drives this, is narrowed it down to 6 inhalers, obviously plus your SAVA, so 7 inhalers in total. So I think, again, the evidence has allowed us to develop this thinking in a proactive way. What else can we do besides pharmacotherapy? So let's just go back to that big yellow document, or the big yellow square, sorry. This is the study, the Sentinel study by Jean Bourbeau from Quebec from 2005, still has very important relevance today, is leveraging self-management and education. If you have access to educators within your own practices, within your PCNs, like certified respiratory educators, we want to utilize them. The intervention of getting the patients to understand it, understand the disease, understand the use of their inhalers, to know that they're using their inhalers properly, making sure that they're using them regularly. All of those factors coming together improves outcomes. And Jean Bourbeau showed nicely 43% reduction in exacerbations in year 1, and in year 2, you still see the signal being very significant. So the reality of the situation is that these interventions work. Many pharmacists are CREs, so if you don't have in-house CREs within your PCN, it asks for you to, maybe take some time to find out if there is, a certified respiratory educator in your area, or maybe just even ask for it on a prescription to see if they'll provide education. But this is a super important part of it. They'll also talk to patients about smoking cessation, and again, that's a whole talk on its own. You're getting that in the next session, which is actually absolutely vital, and then the vaccination portion that we just spoke about. I would strongly consider for you to remember pulmonary rehabilitation. To me, it's not a you should do, it's you must do for when it comes to the treatment of patients living with COPD. You get the self-management education piece within the program itself. They learn the exercises that help them prevent them from becoming deconditioned. And that's, as you've seen, is very important because it changes the kind of the mortality associated with it. And they just overall feel better. And so this study from Rich Castleberry from 2005, I love showing this picture because one of the knocks against pulmonary rehabilitation is that it's the patients stop doing what they're taught in pulmonary rehab. He showed that if you took patients with COPD and randomized them to rehab alone in the circles, or you gave them rehab and you optimized their inhaled therapy, in this case they got tiotropium, LAMA, and you put them through rehab. At the end of the pulmonary rehab period of 12 weeks, you see that the patients who are optimized from their pharmacotherapy versus those who are not, both benefit from rehab, but the patients who are optimized have a much, much better endurance time compared to those without optimized pharmacotherapy. And importantly, you see that this decline happens over the next 12 weeks, whereas with patients who are optimized with therapy, maintain it. That's probably because they feel better, they consistently feel better, and if they're breathing easier and they address the physiological limitation with the pharmacotherapy, they can maintain the exercises. So it's really the combination of non-pharmacotherapy and pharmacotherapy that give you the best outcomes. In our 2015 guideline, which we published with the American College of Chest Physicians, we even showed that getting pulmonary rehab within 4 weeks after an exacerbation can prevent your risk of exacerbations a year later. And we did the systematic review, which shows that pulmonary rehabilitation does work. A 55% reduction in exacerbations if you get them into rehab after hospitalization due to an exacerbation of COPD. So rehab works. Talk to your patients about rehab. We're very lucky in Alberta to have the rehab access that we do. The majority of patients in Canada don't have access to it. We do. We have a very robust program all across the province, and I ask you to consider that strongly. When it comes to the pharmacotherapy, we just don't want to delay. And so when we're being aggressive with our treatment algorithm, is because if we wait to optimize, we fail our patients. So when we wait to give them optimal therapy, there's increased risk of future exacerbations. If they're not optimized, for every 30-day delay in receiving their triple therapy, and this is for hospitalized patients, there's about 10% increase in the risk of subsequent exacerbations in the following year. The 10% risk is not small. There's about a 5 to 10% chance of them dying within the first within the first month, and there's still a 25% of them dying from that exacerbation within the following year. So we got to be mindful of the fact that delaying treatment results in poorer outcomes for them in terms of increasing their next risk of exacerbation as well as mortality. We are advocating for the use now of single inhaler triple therapy. So this study is showing patients who are on single inhaler triple therapy where the ICS, LABA, and LAMA are one inhaler versus multi-inhaler triple therapy where the three medications are provided through different devices. And what you see here nicely in the study is that if in the first few months, if you've got either single inhaler or multi-inhaler therapy, their exacerbation risk seems to be about the same. But around 6 months, it starts to separate out such that after a year, patients on single inhaler triple therapy have a 32% reduction in their risk of exacerbations. Okay, so the evidence is suggesting that that's going to move forward. So, what I've asked for you is that, to go back and talk to your patients about some of this data to say, should we switch? Not everybody wants to, not everyone likes it. And you may want to think, well, if it ain't broke, don't fix it. If they're using their multi-inhaler triple therapies regularly, there's no problem with what's going on. They haven't exacerbated, everything's going well. From Netcare, their compliance data is there, they can use their device properly. You may not want to switch, but know that that's probably, a unique patient because we see that for 25, 30 years, as long as I've been in practice, that the compliance and the technique data suggests that there is a fall off. And you can see here around that 6-month mark, you start to see a separation. That does impact in terms of the compliance and the percentage of patients who are compliant drops off, and the slide just kind of replicates the things I just said. So the last couple of slides I just want to leave you with is mortality reduction an achievable benefit in COPD? Can we get mortality reduction? And so I think it is, and I think if we work together, we can do this. This slide was published in JAMA in 2020, and it was published in JAMA just around the time when the pandemic started. And this is another plug for pulmonary rehabilitation and its benefit. So the study didn't make a lot of noise, but I think it should have. And I show this now all the time. It looks at patients who were hospitalized for an exacerbation of COPD, and looked at patients. It was an administrative database in the US, around 200,000 patients. And it looked at if patients got pulmonary rehabilitation within 90 days. Now, that last systematic review I showed you was getting pulmonary rehabilitation within 30 days. 30 days is a bit tough to get patients to rehab because they might not have recovered from the exacerbation. They may have antibodies to going back to a hospital setting for rehabilitation. There's a variety of different reasons for many patients don't want to go after being hospitalized within that 4 weeks. But if they got rehab within 90 days of that exacerbation, is there a benefit? Is there a survival benefit? And after the course of 1 year, you see about a 30% reduction in mortality if you get rehab within that 90-day period, 30 to 35% reduction in mortality. So rehab works. It improves everything you think of when it comes to objectifiable outcomes when it comes to COPD, and it may have an impact on survival going forward. The pharmacotherapy is also important in this situation. So this is data from the ETHOS study. It looks at patients who are randomized to triple inhaled therapy in a single inhaler versus a lower dose triple inhaled therapy versus ICS LABA versus LAMA LABA. And what it showed, and this was a reduction of 49% when this high risk population that I showed you, the high risk population with the highest risk of mortality are put on optimized in single inhaler triple therapy. You see that there's a 49% reduction in their mortality in the ETHOS study. You see about a 42% reduction in the IMPACT study, which looks at the other triple inhaled therapy, which is Trilogy. So this is the BRESTREE data, and in IMPACT, it's the Trilogy data. You see a 42 and 49% reduction in mortality when optimizing this group of patients. So we don't want to delay patients from getting their best therapy. And we've done the systematic review to show you the data. If you can't sleep at nighttime one day, you want to go to this Canadian Thoracic Society website and our guidelines repository. There's about 110 pages of evidence that you can go through to look at how our recommendations came through. But the evidence is pretty clear that there is reduction in mortality. And again, we believe that the mortality signal is probably most optimal in patients who are on single inhaler triple therapy. So from that same study that showed that exacerbations are reduced when you use single inhaler triple therapy, you see that there's a 33% reduction in all-cause mortality when you use single inhaler strategy versus a multi-inhaler strategy. So again, keeping those things in mind, it's a discussion to be had with your patients moving forward. The last thing I think I just want to mention very briefly, and I've gone a bit over time, is just talking about the environment and inhaler choice that's come up a little bit, and I thought I'd address this. I don't have a slide for this. The Canadian Thoracic Society has put out a document on inhaler choice as it relates to the protection of the environment. The current MDIs available are probably the most problematic, but it's interesting though, in Canada, the majority of the MDI use, and that's problematic for us, is driven by the use of short-acting beta agonists, so the use of salbutamol as rescue, because our patients, whether it's asthma or COPD, are not using their maintenance medications as regularly as they should be, and they're over-reliant on their short-acting beta agonists. If we can curb just that SABA use by putting in good chronic disease management strategies, that alone, in my personal opinion, dampens the impact the MDIs actually have on the environment. That being said, it's there. And all the companies that make MDIs are now moving towards making an environmentally friendly MDI. So this issue is, I think, a bit of a transitory problem for the next 2-3 years until these other ones come out. But rest assured, they are coming out because everyone is concerned. Everybody wants to move forward in protecting the environment. And I think as physicians, we need to be good stewards of this. But the decision should be made, I think, with your patients to find out that what will they take, how will they take it regulated, and will it be the best medication for them going forward. I think that's more important. And in our guideline, we advocate for that approach. That I think again, there's 2 single inhaler triple therapies. They're both very good medications, and if they need that and it reduces their SABA use, you've won. So just keeping that in mind going forward. So with that, I thank you, and I'm happy to answer any questions, and I'll pass the floor back to Denise.
So I just want to thank Mohit for the excellent presentation on the topic of diagnosis management. I just want to have everybody reflect a little bit on how we can use this information in our own practices. So studies have shown that when you have good ideas for your practice, you're more likely to put them in action if you write them down. So we created this free tool for you, which covers both that PPIP thing that the CPSA wants, as well as for credit, and it's called My Lifelong Learning Plan. And if you scan here, you can get it. And actually, if you put in place in your own practice quality improvement program, it'll give you 24 credits. If you do a personal development, like say you do some program on communication or leadership, you can get 6 credits, and standard of practice, for example, 6 credits. So just encourage people to check it out and then give us feedback. But we think it's really, really useful, and we're just so pleased that this time around it got 36 credits, and it's free. And you can also sign up for your NAPCRN reports. So I've got my NAPCRN reports right here, and it gives me information on what's happening with my own panel. And that could be great data that you can then use to implement your plan, and you'll get your repeat data in a year. And that's a helpful way to get some points of reference on your own practice. There we go. And don't forget resources that you have to help you, right? So if you're part of a primary care network, we have improvement facilitators, quality improvement teams. If you have those folks, that might be a place to get some help for your project. Think about the thing that you want to change and how you might want to measure your change. I know for me, just recently started learning more about some of these combined puffers and things, and I still can't pronounce the drugs, so maybe that's my practice improvement, is to learn how to pronounce the names, but also when to use them and how to help optimize care for the patients. And then another way for you to get credits is for you to do the linking learning to practice. So if you go on your main pro page, you can just do a reflection exercise. So if you think about what you learned about today, you can do a reflection exercise, and that will give you 5 certified main pro credits just today on things that you're doing on your reflection. Okay. And in the chat box, there's the link to that in case you don't know where to find it. but it's really practical. And just want to share with everybody before I get to the Q&A that we really appreciate your feedback. So if you could take a few minutes to just complete your eval, because we really want to be reactive to your needs and interests, that'd be super helpful. And we do have a little raffle for this as a thank you for participating in the Q&A, or sorry, in the evaluation. And it's a raffle for a Starbucks gift card, which will close a week from today. And just before we wind up, I want to take a quick moment to mention two of our upcoming events. So we do have the third part of this around how to help patients quit smoking on April 30th. So hope to see you folks there. And we're also going to be hosting a summit on June 11th. Dr. Victor Montorio, who's one of my personal heroes, amazing speaker and thinker, wrote the book Why We Revolt. Really an advocate for person-centered care, is going to be presenting the keynote. And there's going to be a real opportunity for us to build community around change and improvement. So Batty's put a link in the chat on how you could register. Really hope that we see lots of folks there. And just want to thank everybody for coming out, and we'll pivot to the Q&A. Nancy, did I do everything right?
Anything you were perfect. Thank you so much.
Okay, we'll pivot to the Q&A. So the first question, Mohit, is just around the risk of pneumonia and fractures with long-term ICS use. Can you comment a little bit on the magnitude of risk of that and sort of the risk benefit with regards to the triple therapy?
Yeah, that's a great question. And I think that, this is a question that comes up often, and I think it's important to address. So, within the inhaled corticosteroid studies, since the beginning of the first one, Isolde back in the 90s, there's always been a bit of a signal in patients developing pneumonia. Early on, the pneumonia signal was probably a bit higher, simply because of the fact that there was no requirements for quantifying the type of pneumonia that they had. So there was no requirement for X-rays and sputums and those sorts of things. So the how strong the signal was always a bit was debated. A couple of things have happened. One is in randomized clinical trials, there's the requirement to establish a clinical diagnosis of pneumonia. And two, the dosing of inhaled corticosteroids has changed quite a bit in COPD. So in our guideline, I always like to remind primary care about this, is that there's an upper limit, there's a dose response curve limitation with ICS, so that the more ICS in COPD doesn't mean any more. It does not confer any greater benefit. So when Advair was the one that people were using, the 500 dose, BID of Advair was too much. The 250 dose was more appropriate. Now, when we look at the new conventional triple therapy ICSs, they're kind of in that medium to low, medium dose of ICS. So the total dose of ICS has gone down, and thereby the pneumonia signal has gone down a little bit. So it's not as high as it once was in previous randomized controlled trials. So that addresses sort of the pneumonia and the long-term ICS use. But you've got to quantify that with everything else that we do in life, I suppose. Everything we do, every prescription we give, there is a side effect profile with that intervention that we might provide. And so when we look at the studies, when we see a 49 and a 42% reduction in mortality, we see a 25 to 35% reduction in exacerbations, and we see a 2 to 3% signal of pneumonia. It's there. It's not zero, so we can't ignore that. But it's not. You got to sort of quantify it in the realms of what's in the best interest of your patient. So we have to have it in the back of our mind. But it's not something that should drive our management. And if somebody has an untoward event like this, it's not horrible, but it's not great for the patient. But we got to take a look at it at a population level and say, well, it's the overall benefit far outweighs the smaller risk that exists, and that probably is the decision making we've got to make with everything that we do in medicine.
Mm-hmm. Excellent question. Thanks very much, Mohit. So the next one is just around tips on different device and delivery types and what patient they might be used for. So, yeah. So
great question. I think there's a lot of marketing that goes on in terms of my device is better than their device, and their device is better than mine, or their device is limited from that standpoint. I think what's been good and what's been great about having more choice is that we don't have to put a square peg into a round hole. We've got options. And honestly, at this point, I think for the majority of patients that are out there, it's looking at what will they take, what is something that they're comfortable taking, what is that they want to take, because there are nuances with well, all types of inhalers. Dry powder inhalers sometimes require, have taste along with them. A lot of them are once a day. Some of the MDIs are twice a day, because they're maybe having more symptoms in the evening. There may be some rationales to use a twice a day medication. I think it's really having a discussion about these are what's available. This is how this is how you use them, and trying them, and if they don't like it for whatever reason, or if they're not taking it for whatever reason, we have options now to switch. So a bit of a long answer to sort of say that I think they're all effective. It's just kind of trying to find out which one is, the one that they'll take regularly.
And a quick follow-on with that, Mohit, any issues around coverage for any of the different formulations? Like, what's
Yeah.
the story with that?
So that's a great question. So our guidelines is they're progressive, and coverage is not in line in this province with what our guidelines are saying. So since we published the guidelines, we've been very proactive from a CTS standpoint, meeting with formularies across the province. And I met with the formulary here in Alberta. And so we've submitted an application to have the formulary review access, and as it relates to the formulary and how it relates to our guideline. Last week, this is kind of fresh, hot off the press. We think our discussions triggered this, but CADTH, which is the organization in Canada that approves drug indication, is doing a reflective on the COPD medications and their availability as it relates to the new guidelines. So right now, we can't square this or round this square peg at the moment, but I think it's coming, and I think it's coming because we see that the impact that these medicines have on reducing exacerbations, hospitalizations, and mortality. So I think a change may be in there, but right now we're still, got to follow the special authorization form process for it.
It'd be great in the short term, guys, in the Pearls document, if you could give us sort of a primer on options for when funds are an issue, and like if we do have to work around and not use the combined, what would be like the best in the interim? And also if there's things that we have to do prior to the special auth, like have you tried A or B? A little bit of a primer on that might be helpful, at least for me anyways. I'm hoping for the other colleagues. So great question here as a segue on vaccination. So just if you could give us a little summary on Pneumovax and Prevnar, and just give us a reminder about that, Mohit, that'd be great.
Yeah, so I think we want to be optimized when it comes to vaccine standpoint. So I think the yearly flu vaccine for sure. Optimize yourself from a COVID vaccine standpoint. Even now, even with the new variants, we still see that COVID preferentially likes admitting our COPD patients to hospital. So optimizing them from that standpoint. The RSV vaccine, if they're age appropriate to get that one, because we know about 10% of hospitalizations, are due to RSV infections. Around the time of having that discussion. And then I do recommend Prevnar in addition to the Pneumovax, but you got to follow the scheduling that Health Canada set out. The issue becomes a bit of a problem when it comes to cost. all these have costs associated with it, and that's one thing that you need to have a discussion with your patients in regards to that. But I think we do I think it is wise to do it because it's almost 50-50 viral versus bacterial, and still strep pneumonia is still the #1 cause for exacerbations of COPD from a bacterial standpoint. So we want to maximize that benefit, but cost is always the limiting factor. And again, we're trying to make a bit of an advocacy for this. I'm in the introduction, you introduced me as president, but I just gave up the presidency last week. My term came up last week for the other Canadian Thoracic Society, but we put out a joint, while I was president, we put out a joint statement with AMI Canada, which is the Medical Microbiology Association, regarding the need for funding for vaccinations. And I wrote a couple of pieces as a president's message to advocate for that. So I think this is important. Specialists, primary care, everyone get together. And when we're worried about this, surge every, fall, winter for hospitalizations, and we know these vaccines can reduce this. I think it's a shame that these are not publicly funded. And we saw with COVID firsthand how a good vaccine strategy can reduce hospitalizations. And I think we need to be more proactive when it comes to this as a healthcare society.
Oh, super, thanks. Great question here in terms of someone who's continuing to smoke and doesn't yet have sort of diagnosed COPD. you showed that really helpful questionnaire, which I'm assuming will be in the Pearls document. But how often should we consider perhaps doing spirometry in someone? You stressed the importance of early diagnosis.
Yeah, that's a great question. So I can't give you any evidence, but I can give you anecdotal responses. So that's the question. So we don't want to screen for COPD. So the U.S. Task Force on Preventative Medicine suggested that don't send everyone off for spirometry because it's not cost effective if you're thinking about COPD. So you want to target the patients that have, that risk factor of at least 10 pack years, smoking history, or ex-smokers with that chronic respiratory symptoms, or have other exposures that put them at risk. If they come back with normal spirometry, I don't have a good answer for you, but I would say potentially yearly, because there's no trajectory that suggests that, in a year of ongoing smoking that they're not going to hit that part of their environment and genetics that will cause them then to dive off very quickly. So you could send them off for spirometry on a yearly basis. It may be a bit aggressive, but it may also be protective to them, because if you find that they've evolved that early stage of disease, then maybe that's when they recognize the importance of smoking cessation or changing the risk factors that are driving the disease. But I appreciate the fact that the person who wrote this question said spirometry, not full PFT, because that is important to go for spirometry. It's again, low cost, easy test to do, but there is no recommendation on it. There was a randomized controlled trial that was just published in the New England Journal of Medicine late last year, looking at whether treating this patient's smoking history, normal spirometry, and put them on inhaled therapies, and would that make a difference to their outcomes? Because even this population tends to be hospitalized for respiratory related problems. And in that study, it was a negative study. So without having spirometric confirmation of COPD, there's really no benefit of adding an inhaler.
Interesting. Okay. So next colleague's asking, just, logistically, you mentioned that in Alberta, we're really privileged to have pulmonary rehabilitation. And it's not clear from the question where this colleague might physically be located, but can you talk a little bit about how we can access pulmonary rehab?
Yeah, so in Edmonton, there's a 1-800 number essentially and I don't have the number off the top, but if you Google pulmonary rehabilitation Edmonton or Breathe Easy program, there'll be a centralized intake form. What you need is spirometry done to confirm the diagnosis, a chest X-ray in the last year, and an ECG. Those are the three pieces that need to be sent in with that. Then the team then calls the patient and then finds out where they best need to go for the rehab. So there's a few satellite centers. We just recently moved the program from the Edmonton General Hospital to a newer site at the Norwood by the Royal Alex. So it's a brand new facility there for us here in Edmonton, but there are some satellites around the city and definitely around northern Alberta, where there's satellite clinics that either tap into the Breathe Easy program in Edmonton, or, for example, the Southside Primary Care Network. I'm the medical director of that program there, and then we run that essentially quarterly, like 3 to 4 times per year is what we run it. So patients, who want to come to a site that's not downtown, we have access to that. So if you just Google that, you'll find the referral forms and the requirements, and it's just a very simplified process.
Fantastic. And just a plug, guys, for our colleagues, like we have beautiful respiratory therapists and PCNs, and they can be just like such a tremendous resource and help around just even some of the basics, and getting people in and getting connected and helping us navigate these resources, right? So don't forget your own RTs. Awesome. And so looks like we've got somebody summing up everybody's sentiments here, Mohit. One of the colleagues is sharing, thank you very much. Lots of very useful pearls, very relevant clinical information. I think I echo all the colleagues on the call and those who will be listening asynchronously when I say thank you very much. I think this is just tremendous, and really value you taking time, to share with us. And I think there is generally an interest in that follow on exacerbation. There's been some questions on the needs assessment, and hopefully we can inveigle upon your good nature to help us and continue to help us with that learning. It'd be fantastic.
Oh, of course, yeah, happy to help. Love working with you guys. So absolutely, yeah.
Yeah, awesome. Okay, guys. Well, I'm really pleased that we are precisely on time. So we'll give everybody the gift of their evening. Just thank you so much for making time and joining us. Nandini, have we done all the bits that we need to do?
We have indeed, and more. So that was great. And
Yeah,
thanks.
so put your hat in the ring for the coffee card, guys, and scan me here and provide some feedback and some input. Really value everybody taking time. Thank you so much.
Thanks, everyone. Good night.
Okay, good night. Take good care.